సడన్గా బ్రెత్లెస్నెస్ అనేది స్టార్ట్ అయింది. కదా కాల్ చేయగానే వెంటనే ఎమర్జెన్సీలో అవైలబుల్ ఉన్నారంటే ఫౌండ్ అవుట్ దట్ షీ హ్యాడ్ స్వైన్ ఫ్లూ అనమాట. ద నెక్స్ట్ కపుల్ ఆఫ్ డేస్ సిచ్యువేషన్ స్టార్టెడ్ డిటీరియోరేటింగ్ అనమాట. సో అట్ దట్ పాయింట్ ఆఫ్ టైమ్ వీ ట్రస్టెడ్ ద డాక్టర్స్ కంప్లీట్లీ. దే స్టార్టెడ్ ట్రీటింగ్ హర్ విత్ ECMO. సో రైట్ నౌ ఆన్ మినిమల్ ఆక్సిజన్ షీ ఈస్ గెటింగ్ డిశ్చార్జ్ టు హోమ్ అనమాట. Hello, I'm Pranav from Hyderabad. So we live in high-tech city nearby. On September 1st, మా మదర్కి సడన్గా బ్రెత్లెస్నెస్ అయ్యారనమాట. సో సండే కదా డాక్టర్స్ ఎవరు ఉంటారు అని యశోద కాల్ చేయగానే వెంటనే ఎమర్జెన్సీలో అవైలబుల్ ఉన్నారంటే వీ డిడ్ంట్ వాంట్ టు టేక్ రిస్క్. వెంటనే ఇంటికి దగ్గరే కదా అని ఎమర్జెన్సీకి వచ్చాము. అండ్ ఏంటంటే మేము నార్మలే అనుకున్నాం కానీ డయాగ్నోసిస్లో వీ ఫౌండ్ అవుట్ దట్ షీ హ్యాడ్ స్వైన్ ఫ్లూ అనమాట. అండ్ దెన్ వీ స్టార్టెడ్ టు పానిక్ బట్ డాక్టర్స్ వర్ దేర్, దే కామ్డ్ us. అప్పుడు దెన్ వీ మెట్ విత్ రవిశంకర్ గారు హూ ఇస్ క్రిటికల్ కేర్ యూనిట్ సీనియర్ కన్సల్టెంట్ along with Dr. Somnath Gupta garu. They explained the scenario to us. So they were like, meer confident ga undandi, we are trying our best ani. And then in the next couple of days situation started deteriorating anamata. We started panicking, but they told that there is one more method called ECMO, which is the highest form of life support, and that they can still revive her. సో అట్ దట్ పాయింట్ ఆఫ్ టైమ్ వీ ట్రస్టెడ్ ద డాక్టర్స్ కంప్లీట్లీ. మాకు తెలుసు వాళ్ళందరూ క్వాలిఫైడ్, దేర్ ఒపీనియన్స్ ఫర్ పర్ఫెక్ట్ అని. వాళ్ళు చెప్పగానే ఇంకా వీ వెంట్ అహెడ్ విత్ ఇట్. సో దే యాక్టెడ్. వన్ గుడ్ థింగ్ ఇస్ మేము మల్టిపుల్ సెకండ్ ఒపీనియన్స్ తీసుకున్న. వాట్ ఎవర్ దే డిడ్ వాస్ ద బెస్ట్ థింగ్ వాస్ దే యాక్టెడ్ ఫాస్ట్. వాళ్ళంత పర్ఫెక్ట్ టైంకి ఇంటర్వ్యూన్ అవ్వడం వల్ల. అండ్ టుడే వీఆర్ సిట్టింగ్ హియర్ అండ్ ఐఎమ్ టాకింగ్ టు యూ పర్ఫెక్ట్లీ బికాస్ మై మదర్ ఇస్ అబౌట్ టు గెట్ డిశ్చార్జ్డ్. సో ఈవెన్ ద నర్సింగ్ అండ్ కేర్ గివెన్ టు హర్ వాస్ టాప్ నాచ్. And security officials gani everything was good. We are very happy about whatever treatment we received, and we are grateful to Yashoda Hospital for saving our mother.
So we're all here to share the success story of our one of our patients, Mrs. Kavika, who had come to the emergency with swine flu infection, influenza. Influenza is a very common infection. We see every year, we have been seeing this H1N1 or swine flu for the last 15 years. But what makes Kavita unique is the severity of disease. 0.1% of all patients with swine flu will develop what is called as a refractory ARDS, which means within days the virus will spread all over the lungs. The patient can't breathe. She will go on ventilator, and even after ventilator, the lungs will not be in a position to send oxygen which is required into the bloodstream. That is called as refractory ARDS, which means the most severe form of lung infection which we can ever encounter. So when we have such patients with refractory ARDS where even a ventilator is not helping them, so what to do? So the only option left with us was what we call as ECMO, extracorporeal membrane oxygenation, which is nothing but artificial lungs. So while we treat the lungs, while the lungs take time to recover, we will put an artificial circuit, and that will help circulate oxygenated blood across the body so that the body will survive. So this is what we had done. Timely initiation of ECMO. We have an extremely good critical care medical team and an ECMO team who will look carefully into these intricate details of the ECMO. The journey is a long journey spanning over 5 to 6 weeks, but during this course of 4 weeks of ECMO also we encountered a lot of complications. There were some infections, there were some bleeding complications, there were some weakness, but all of these complications were identified timely, intervened correctly, and we could overcome each of these complications. And successfully, after 6 weeks of admission, now she is in a position where she can talk, she can breathe, she can walk, and then we are able to send her home happily. So we are all very happy for the patient and as a team that we could give her a new life. So this is nothing but breathing a new life.
There were multiple challenges in the context of this patient. She is a diabetic with uncontrolled sugars, and she is very obese and with severe hypoxemia. But despite these challenges and all the odds, we could initiate VV ECMO in her. And even after initiating VV ECMO in her, she was able to maintain the oxygenation at a very low level despite highest possible supports. At this point of time, we even contemplated of doing a lung transplant for her. But fortunately, with whatever efforts with our team, including the pulmonology team as well as the general medicine team, we could successfully recover her from ECMO after 35 days of ECMO support, venous ECMO support for her. And the most interesting or the crucial facts in her case was, despite all these odds, she was awake all the time and we could preserve her power without any weakness. Even after 35 days, she was sitting on a wheelchair and she was able to do the physiotherapy. Except for slight weakness in her lower limbs, she was subsequently decannulated and shifted to the home with oxygen support.
She came to emergency with complaints of fever since last 1 week, breathlessness and cough. Breathless was not more severe, but she had a vigorous cough since 1 week and she had a weakness, headache, body pain. She has almost no comorbidities. We evaluated and found to have ABG shows respiratory acidosis. Her oxygen levels are very less. She came with room air oxygen levels around 60%. And when we did a CT test, we could find that there is a diffuse lung involvement, looks like a picture of acute respiratory distress syndrome. And then we admitted her immediately into an ICU, where we could see that PO2 by FO2 ratios are very less and she clearly fits into a category of ARDS. And gradually her oxygen levels, we started on oxygen support, we started on NIV supports. Even after that, oxygen levels are not improving. When we routinely investigate in all the investigations, we found that WBC counts are low, platelets are low. She had a blood pressure around borderline 90/60. We kept on inotropic support. With one inotrope, her blood pressures are not maintained. We increased inotropic support to dual inotropic support, and gradually her urine output has come down. Then we thought of ventilating her. We started intubated, kept on ventilatory supports, maximum ventilatory supports. Even after that, her oxygen levels are not improving. Gradually, we kept on prone position and maximum ventilatory supports with high PEEP and increased pressure supports. Her oxygen levels are not improving. The patient level consciousness increased. We started on dialysis support because of decreased urine output, started on multiple antibiotics. Even then we got a diagnosis. We did a Filimara test where we could find that she was positive with influenza AH1, swine flu. Then we started her on oseltamivir with antibiotics, hydrocortisone coverage and inotropic support. And even after that patient is not improving, then we counsel the attenders in detail about requirement of ECMO supports. So then we started in VA ECMO, we started in hemodialysis. Patient was gradually managed. Slowly the supports has been decreased, but there was a lot of challenges during the hospital stay. There were a lot of nosocomial infections added up with a gram positive, gram negative. There are multi-drug resistant organisms. Almost like 5 to 6 superbugs has been infected. We changed the antibiotics. We started on ceftazidime, avibactam, as well as we started on azithromycin synergy. And patient gradually her supports, ventilatory supports has come down. Inotropic support has been weaned off. With urine output started pouring, the dialysis support has been completely stopped, and finally after 30 to 40 days of ECMO, we could able to stop ECMO supports and we started slowly weaning off ventilatory supports. And with the God grace, with the hospital management as well as with the support of the patient attendees, mainly their patient levels, and they could able to afford such a high risk case, and with the support of ICU team and pulmonologist Dr. Nagarjuna, we could completely stop the ventilatory supports. Patient was out of tracheostomy. We have weaned off all the inotropic supports. Antibiotics have been stopped. With small minimal oxygen support around 2 to 3 liters, we could comfortably discharge the patient after almost 50 days of huge struggle.